Down syndrome is the most common genetic defect and the most common trisomy. So remember one thing before we jump into Down syndrome. So you know that 21 is the most common, that is followed by 18, then 13. So there's a concept here, the initial number of chromosomes, that is the chromosomes 1 to 10 and 1 to 15 are more important than the later ones. So whenever there is a trisomy involving first chromosome, fifth chromosome, sixth chromosome, it is usually fatal. So that usually ends up having an abortion or a miscarriage. So as the chromosomal number increases, the severity of the disease decreases. So amongst these three, Downs is a milder form, Edwards is something moderate, and 13 Patau syndrome is very, very severe. So you have to remember the concept. As the number of chromosomes decreases, the severity of the disease increases. So as the number increases, the chances of that baby surviving also increases. So that is why most of the Down syndrome patients survive. So not many of these people survive 18, but 13, most of them die in utero, and even the babies who are born with 13 the trisomy, they do not live longer than a few months. Most of them expire within first 2 weeks. Okay, so that is a concept about chromosomal disorders. We'll start with Down syndrome. You all know that it's the most common chromosomal abnormality. Okay. So the incidence is around 1 in 730 live births. So this incidence is quite tricky. So when it changes with the maternal age, you all know that with maternal age, so the meiotic apparatus is also going to wear off. So as the increasing age more than 35 with each year, so the incidence of Down syndrome increases to quite a lot. So that you have to remember. Okay, then it is also the most common genetic cause of intellectual disability. Overall, this is the most common. After this, you have other syndromes like Fragile X syndrome and autism. So you must be aware about three mechanisms of Down syndrome. The first one, almost accounting for around 95 percentage, is meiotic non-distinction. We have already discussed what is that. This Robertson and translocation accounts for around 3 to 4 percentage. So you have to remember this as well. This is the second mechanism. And the least commonest is mosaicism, that is 1 to 2 percentage. So why is it important for us to know this? This is very important because once you diagnose Down syndrome, you have to know what was the cytogenetic abnormality. That is because based on this abnormality, you can basically predict the recurrent risk in the next pregnancy. So this is very important for the parents to know that you already have one child with Down syndrome. It is going to be disaster again for the next child again being a Down syndrome. So it's very, very vital importance. It's very important to know why exactly this particular syndrome has occurred in this patient. So if we isolate that, then we know the recurrent risks. For example, with the classical non-meiotic non-disjunction, the recurrent risk is less than 1% like the normal population. So only the age matters here. There's no recurrent risk, especially more than normal population. With Robertson translocation, the recurrent risk changes. So we'll discuss that. Okay. So what is Robertson translocation? So for example, this is an acrocentric chromosome. So there is a translocation here. So here, both the long arms have joined of different chromosomes. Short arms which have joined are usually both the short arms together form a very small chromosome. So this fragment is usually lost. So there is overall a loss of one chromosome here. So this is what Robertson translocation means. So there is a change or exchange of the long arms and short arms amongst the acrocentric chromosomes. Okay, so this is an acrocentric chromosome which has small and a long arm, and this is another acrocentric chromosome, a small and a long arm. So when there's a translocation which is happening after breakage and rejoining, both the long arms join together and both the short arms join together, and short arm is completely eliminated. So this is completely lost. There's a loss of chromosomal material here. So this is called Robertsonian translocation. So why is it important in Down syndrome? Here it is important because this translocation can occur between chromosomes 21 and 13/14 or 15 or even 21. So remember here, it's very important to know this. So that is the reason with any patient of Down syndrome, we have to know exactly why this has happened. So in Robertson translocation of 21 and 13, 14, or 15, any of these. So the recurrent risk, if the female was a carrier, it is 15%, and male it is 5%. With 21 and 22, that is 21, between 21 and 22, the translocation occurred. So the recurrent risk is almost same. The female carrier is 10% and male carrier is 2%. Always remember the female carrier will have a more chance of recurrent risk, because you all know that female with each year the apparatus is going to wear off and it's going to have more chances of producing the disease. But remember, this is the most important and the most often asked question. If there is a Robertson translocation between 21 and 21, remember this here, either it's a male or a female, the recurrent risk is 100%. So this is something you have to remember. So this is very crucial to know, because this is 100% the next pregnancy is going to be disastrous for the parents. We have to counsel them accordingly. So this is how important that we know what exactly is the type of Down syndrome. So that is why we stress on prenatal screening and prenatal confirmation of which type of chromosomal aberration has caused this Down syndrome. Okay, so this is Robertson translocation, accounting for around 3 to 4%, but the most common mechanism is meiotic non-distinction. Okay, coming to the clinical features of Down syndrome, you all know that Down syndrome typically has a facies known as Down facies. Also remember, previously we used this term called mongoloid faces. So this terminology is being disgraced now because it is not ethical, because we're comparing this to a race. So this term is not used anymore. We use the term Down facies to describe any patient with suspected Down syndrome, because they're very characteristic. They have this typical mongoloid slant, or it's epicanthal fold here. Okay, and there is a flattened nasal bridge. This is a very characteristic feature. Okay, they can have hypertelorism also, and you have low set ears. See, if you see here, the placement of the ears is abnormally in the lower portion of the face, so that's a low set ears. You have up slanting palpebral fissures, so that's something like this. So normally you have palpebral fissures like this, which are oriented. So you have an up slant of palpebral fissures. Okay, and you have short neck. So we have a lot of deformities in the neck. We'll discuss about that in the next slide. So you have short neck. You also have brachycephaly. Okay, you have flat skull in the posterior side. Okay, apart from that, you also can have microcephaly, and there's a specific manifestation in the eyes which is called brush-filled spots. They have whitish spots on the iris. So this is very often asked in your exam. Okay, and Down syndrome patients can also end up having blue dot cataracts. So these cataracts are basically peripheral. Okay, so when they're peripheral, so usually they do not interfere with the vision. So remember these two manifestations in the eye. Okay, and you also have macroglossia and protruding tongue. Okay, in the feces. So, and also usually Down syndrome patients are prone for obesity. So in the face you can see that obese looking child. So these are some facial phenotypic features of Down syndrome. So when we look into the systemic manifestations, as we discussed that it's the most common cause for intellectual disability. So usually IQ will be somewhere lower than 80. So you have brush-filled spots. We have discussed this, and there is a significant short stature in Down syndrome. You can have hearing loss, recurrent otitis media, because the bony architecture is different. It's prone to infection. You can also have sensory neural defects. Remember, the endocrine system is inherently affected in Down syndrome. You can have hypothyroidism and also celiac disease. Remember, celiac disease is also common in Down syndrome. Okay, and you can also have autoimmune thyroiditis causing hypothyroidism. So you have autoimmune diseases like celiac disease, hypothyroidism, etc. Okay, in the cardiac malformations, you can have ASD, VSD, but what is the most common defect? It is called endocardial cushion defect. Endocardial cushion defect is the most common defect seen in Down syndrome. Almost 50% of Down syndrome end up having some cardiac malformations, 30 to 50%. Okay, so we can also have very characteristic gastrointestinal malformations like duodenal atresia, annular pancreas, okay, and also Hirschsprung's disease in the rectum, okay, and urogenital malformations like hypogonadism. So that is the reason you have low fertility in men because of azoospermia, okay. So usually males end up having infertility, okay, so low fertility, and females usually are fertile and they can produce children. So in the phenotypic features, other phenotype you can have obesity and a very characteristic feature which is called sandal gap. Sandal gap is basically gap between the first and the second toes of your foot. Okay, this is also feature. And then you have joint problems like lax joints. You have hyperextensibility of joints in the neck. You have a very characteristic feature which is called atlanto-occipital instability. So what does this mean? We have to get an MRI in any child of Down syndrome to know this whether it's there or not. So this is a very sometimes it can become a very life-threatening event if you handle a Down's patient, or if you're trying to intubate this child, or you're trying to mobilize this child. So you have to be very careful. You have to put a cervical uh, support or a brace to prevent dislocation, because there is already an instability. So this instability can easily go and cause dislocation and injury to the cervical spinal cord. So this can end up in quadriparesis. It's a very life-threatening and a dangerous situation which can cause significant morbidity. So you must look for this by doing an MRI of neck. Okay. So antenatally, you have nuchal translucency. So there is a lot of problem which is happening in the neck region. Antenatally, you have excessive fluid accumulation in the neck region, in the posterior aspect of the neck. So that is called nuchal translucency. We'll look for that in the antenatal scans. In the postnatal period, you have this excessive fat accumulation in the back of the neck, and in the bones, you have this atlanto-occipital instability. Okay, in the palms, you have this single, and unlike us, we have two or three palmar creases. Here in this Down syndrome, we have a single palmar crease. This is called, can you guess what is the name of this? So this is called simian palmar crease, or single palmar crease. Okay. So you have other manifestations in the hand like clinodactyly, brachydactyly, and camptodactyly. Okay. Along with it, you can have umbilical hernias. And because of the joints in the bones which are not growing properly, you can have delayed motor development and a very significant clinical finding that is in the neurological manifestation, that is hypotonia. You have significant hypotonia. So these are the organ systems which are involved in Down syndrome. So apart from this, there are some other manifestations like, for example, these children are prone for a condition in the first infancy which is called transient myeloproliferative disorder. So this is also called a transient leukemia. But usually resolves by itself, but in some rare conditions this can progress into leukemia, that is ALL. So apart from this, Down syndrome patients are more prone for leukemia. In leukemia, ALL is the most common one, followed by AML. Okay. And in AML, there's a specific type of AML which is called M7, which is more common in Down syndrome. Okay, so AML M7 is basically acute megakaryoblast leukemia, AMKL. So acute megakaryoblast leukemia. So this is M7. But if they ask you what is the most common is ALL like anybody else. After that, AML M7, which is very specific in that M7 is the most common seen in Down syndrome. Okay, apart from this, there are some other problems in Down syndrome as well. For example, Down syndrome patients are prone for early onset Alzheimer's. Okay, this you have to remember, a very important and often asked question. Okay, apart from this, there is a particular problem in the, have you heard this term in forensic? This is called dermatoglyphics. So dermatoglyphics is terminology wherein, the fingerprints, for example, fingerprints are divided into ulnar loops, radial loops. So that pattern of fingerprints is also different in Down syndrome patients. You tend to have more of ulnar loops. So this is how, Downs, as I discussed, chromosomal disorders are usually diffuse, they involve almost all the organs in the body. So they have diffuse multisystemic involvement of diseases. Okay, this is about the clinical manifestations of Down syndrome. Okay, so we have discussed this is a normal crease pattern in a normal child. So this is a single crease. Okay, this is called simian crease. And there's another variant which is less common than simian crease. This is two lines. So this is called Sydney crease. Okay, then this is the sandal gap we have discussed about. This is sandal gap. And can you guess what is this crease in the foot, in the sole? So this is called Kennedy crease. This is also seen in Down syndrome, but less commonly seen. This is called Kennedy crease. So we have simian crease, we have Sydney line, and also Kennedy crease and sandal gap along with it. So these are some characteristic features of Down syndrome. Okay, coming to prenatal screening. So you all know that after if you suspect a patient with Down syndrome, so you can diagnose that patient with karyotyping. Okay, karyotyping, you will see trisomy of 21. Okay, so but here the question is that we have to diagnose this illness before pregnancy. So that is very important because it is one of the commonest trisomy. So routinely every mother is supposed to have a prenatal screen for Down syndrome because the incidence of Down syndrome is very high, especially in mothers who are aged, so more than 35. These mothers need an extra care to make sure that prenatal screening for trisomies or aneuploidies must be done. Okay, so what do you do basically? You call the mother at around 9 to 11 weeks. Okay, or sometimes 9 to 13 weeks. So this is in the end of first trimester. So this is in the end of first trimester. So at this period, the first test you get done is basically an antenatal ultrasound to look for nuchal translucency. That is called NT. Okay. The second thing what you do is you get a blood sample from the mother and you basically get a test called double test. So we'll look into what exactly double test is. So these are the tests you get done at first trimester. Okay, based on this, then you ask them to get the reports and follow up at around 16 weeks. So anywhere between 16 to 18 weeks. Okay, you can get it from 15th week also. Sometimes extend till up to 21 weeks. So at this particular point, you have to get a quadruple test. Okay, so at first trimester ending, you get a double test plus nuchal translucency and quadruple test. So this double test plus nuchal translucency, this is called a combined test. Okay, so this combined test plus quadruple test together is called integrated test. Okay, this integrated test plus a nuchal translucency test done in the second trimester also, this is called a fully integrated test. So what does this mean? Basically, this is a screening method. So we are looking at markers. We are not directly looking at the karyotype of the baby, whether it's 100% Downs or not. So these are indirect markers. These could probably indicate that you're dealing with a trisomy and specifically Down syndrome. So this, if you do all of this, the sensitivity of these screening tests will reach almost 90%, 85 to 90%. Okay, so this is what is followed. So whenever this screen is positive, and then you go and get a confirmatory test. This is the concept of prenatal screening. Okay, so we'll look at this prenatal screening in detail. So I was talking about nuchal translucency. So this is a normal fetus wherein there is a normal thickness. So this is a nuchal tissue with normal fluid here. So this is a fluid here in the posterior aspect of the neck. So this is a normal thickness. Okay, this is a normal fetus. So when you have excessive fluid, see when you see here the entire fluid, there is an excessive accumulation of fluid here. So this thickness of the nuchal tissue is increased. So this is a sign that probably the child has Down syndrome. Though this is not specific for Down syndrome, but this indicates that we are probably dealing with an aneuploidy or a trisomy. So this nuchal thickness is also increased in a condition which is called cystic hygroma. Cystic hygroma is seen in Turner syndrome. Okay, it's usually seen in Down syndrome, but can also be seen in cystic hygroma. So what I mean is this test is not specific for Downs, but it can give you a clue that we're probably dealing with Down syndrome. So this, along with other screening tests, will be a very good sensitive test for Down syndrome. So you have to remember these 5 markers. A very high yield question for your exam. So what is this? This is called pregnancy associated plasma protein A. This is beta HCG, human chorionic gonadotropin. This is alpha fetoprotein. This is unconjugated estriol. Okay, unconjugated estriol, and this is inhibin A. So remember 2 things here. In Down syndrome, alpha fetoprotein is decreased. Okay, and unconjugated estriol is decreased. So everything else is increased. So this is the first thing you have to remember. Okay, so coming to the next thing, so we have discussed this in the first trimester, that is somewhere between 9 and 13 weeks. You get a simple serum sample from the maternal blood, and you do this double test. So you look for PAP-A and beta HCG. This is called double test. And you see that both of these are elevated in Down syndrome. If that is elevated, then probably it is a screen positive Down syndrome. So this double test along with nuchal translucency, that is antenatal ultrasound. So this together is called your combined test. Combined test is usually done in first trimester. Okay, when you combine beta HCG, AFP and unconjugated estriol, this is called triple test. Okay, some institutes do this also, but remember, what is this? Beta HCG, AFP, unconjugated estriol and inhibin A together, this is called quadruple test. So this is done in the second trimester, that is somewhere between 15 to 18 weeks. Okay, when quadruple test is combined with combined test. Okay, when combined with PAP-A, so this becomes your integrated test. So that's what I'm talking about. So when quadruple test and PAP-A is included, so this is called integrated test. So this is an integrated serum test. Okay, so you're doing all 5 markers. Okay, so this plus nuchal translucency, and this is called a fully integrated test. Okay, this is called an integrated serum test, and this is called fully integrated test. So there are few blood tests and only one ultrasound test which we do to predict that probably the child has Down syndrome or not. Okay, so we'll have a quick revision. So you know that in Down syndrome, what happens? There is decrease in the AFP and decrease in unconjugated estriol, and everything else is increased. Okay, so you have also remember this prenatal screening test is also useful to diagnose other aneuploidies like other trisomies as well. So at the same time, we try to remember other diseases. For example, in Patau syndrome and neural tube defects, the AFP is elevated. This is very, very high. Okay, and when it comes to Edwards syndrome, that is trisomy 18, beta HCG is very low. So this is something you have to remember in Edwards and Patau's and neural tube defects. So these can also tell that we're probably dealing with other aneuploidies as well. So this is the next investigation. This is a cutting edge new technology. So what is the concept here is this was not known before. So the fetal genetic material is transferred via the fetal vasculature into the chorionic venous or villus blood vessels and into the maternal circulation. This is the maternal blood stream. So the concept here is that the fetal DNA is freely moving around, freely roaming around in the the maternal circulation. So normally what we know is genetic material is usually inside the cell. It's transmitted that way. But this concept is something new. The DNA and the genetic material is directly freely moving in the maternal bloodstream. So what we do, we collect the maternal blood sample and we look for the fetal DNA, and in that DNA we look for the fetal anomalies, that is in the chromosomal problems, that is by karyotype. So this is called, because it is not bound to the cell, inside the cell it's freely roaming around, so this is called cell-free fetal DNA. Okay, so also called as CF DNA. So another aspect here is, usually to confirm or to see any direct genetic testing in the fetal DNA, we usually go and take an amniocentesis. When we put a needle into the amniotic sac and we collect the sample, that is amniotic fluid analysis, that is by amniocentesis. Or another technique wherein you put a catheter inside and directly go into the chorionic villi. So this is called chorionic villus sampling, and this is called amniocentesis. So these are some definitive tests. So we have looked at prenatal testing, wherein we collect some blood samples and do an ultrasound of the neck, the fetal nuchal translucency. So these are some confirmatory tests, that is CVS and amniocentesis. We'll discuss about this in the next slide. But this and this, both of these are invasive tests, wherein we put a needle inside, we put a catheter inside. Unlike cell-free fetal DNA, we just take a sample from the maternal blood. So that's why this is called non-invasive prenatal testing. A very, very important concept. This is called NIPT. Okay, when compared to NIPT and amniocentesis and CVS, amniocentesis and CVS still remain the gold standard, but NIPT is a newer concept which has come and which is non-invasive. So that is why you have to know, and it's being done. So disadvantage for that is that basically we have to interpret whether that DNA is fetal DNA or maternal DNA. So we have to look for fetal fraction. So that is called fetal fraction. The fetal fraction should be adequate to know whether that the genetic material we have tested for aneuploid is the chromosomal microarray or karyotype. We have to be sure whether it's fetal or maternal. So we have discussed this amniocentesis and chorionic villus sampling. So you all know that. So as we all know that these are confirmatory tests. So these are very accurate. We have looked at the serum screening tests and NIPT, but the gold standard still remains either via amniocentesis or chorionic villi sampling, just because we are directly looking into the fetal tissue. Because you all know that amniotic fluid has fetal cells. Okay, and here we are directly taking the material from the villi, which is also a fetal material. So we are directly looking at the fetal tissue. We are looking at the karyogram or the karyotype or the chromosomal microarray. We are directly looking into the fetal tissue. So that is the reason it is a confirmatory test. So always remember, tissue diagnosis is always a confirmatory test in any disease or any disease in medicine or pediatrics. Usually, when we directly take tissue, for example, infected endocarditis or tuberculoma or tuberculosis or any malignancy, lymphoma. So there are a lot of screening tests. We do an imaging test, we do X-rays, we do biomarkers, tumor markers. So all those tests are probable clues, and that's why they're called markers. But always confirmatory test is going to be tissue diagnosis. Here also, to look at the genetic disease, we're directly taking tissue material from the fetus. So that is why this becomes your gold standard. So first thing, it is very accurate. Okay. Second thing, you have to remember, amniocentesis is usually done at around 14 to 16 weeks. Chorionic villus sampling is done little early, that is in the 12 weeks. So here we insert a needle here, and here we insert a catheter into the transcervical route. Okay, then what are the problems here? There is a slight chance of miscarriage which can happen with these procedures. Now, with amniocentesis, the risk is very, very low, that is 0.5% to 1% of fetal loss. This must be counseled to the parent. This is always there, but the percentage of that is less. Okay, with chorionic villus sampling, the chance is around 2%, that is fetal loss. So this is usually performed at 12 weeks, that is early, because the later you perform, that can cause problems in the fetus. So sometimes 1 in 3,000 chance of limb malformation can occur. So whenever I take the sample, that part of the fetal tissue can be disturbed, so that part can produce a limb malformation. So that is the risk which you have to explain to all the parents before you counsel them. So that is about your prenatal confirmatory test. That is why amniocentesis or chorionic villus cell sampling. So this, after that, you send it to a karyotyping or chromosomal microarray. So then you know basically what is happening. If you're suspecting a monogenic disorder, you can send this to next generation sequencing, that is clinical exome. So this is how it is done, and you can counsel the patient accordingly. Okay, this is the karyotype, typical karyotype of a Down syndrome. It's often asked in your exam. This karyotype can be shown as a pictorial question. So you have to look at all the chromosomes. You see all are in pairs, but except for 21, the 3 chromosomes here. So this is trisomy 21, and it's Down syndrome. Okay, coming to the management of Down syndrome, so Down syndrome counseling should be done, which is a multidisciplinary approach. So we have to look at multiple aspects of Down syndrome. So first thing, Down syndrome is not a bad thing. It's not a death sentence. Down syndrome patients can live their own life. They can feed themselves, but they need a lot of support from parents as well as teachers and also from doctors. So consistent therapy, because they have joint laxities and hypotonia. So therapy is very definitely useful. So that can be in the physical therapy. You can have, so Down syndrome patients also have speech delay. Okay, occupational therapy can be given. So remember, Down syndrome patients have special problems like dysgraphia. So they have fine motor problems. They can't hold writing. Writing can be a problem, and especially learning gadgets. For example, like the normal peers, they can't usually type the computer well. So they have special keyboards. They're called down keyboards, wherein the alphabets are very huge. The keys in the keypad are very big. So they have special pencils also. They're called trifaceted pencils, wherein it's easy to hold. So there are a lot of Down syndrome assist devices wherein this is called three-sided pencil, touchscreen computers, and keyboard with large letters I was talking about. Okay, and these children have a lot of problems like congenital heart defects. You have to screen them with echocardiography regularly. Okay, you have to have screening for gastrointestinal issues like celiac disease. Okay, you have to look for IgA anti-TTG antibodies. Okay, then you have to get serial TSH levels, because these children are prone for hypothyroidism. If they're already positive for hypothyroidism, they have to be on regular medications with levothyroxine. So this is a multidisciplinary approach, and always look for Atlanta-occipital instability. Okay, because this is potentially life-threatening. Okay, frequently or every few months you can get a hemogram done to look for WBC count, because these children are prone for leukemias. Okay, especially ALL followed by AML 7 M7. Okay, and also look for multisystemic diseases like gastrointestinal, CNS defects, heart defects, joint problems, puberty problems, obesity. So it's a multidisciplinary approach. You have to call them frequently, look for all the systemic problems, and then follow them up accordingly. Okay, that is the management of Down syndrome.